Good morning, good afternoon, good evening. Dr. S. Dr. Forward here for NUR 114. So I am going to give you a voiceover on the concepts for NUR 114, and we start Module 1 with the concept of elimination. So using your Gideon's textbook, you can go to chapter 15, and yes, this is the Elsevier PowerPoint. So basically what I do in 114 is I'm not coming into class talking about the concepts. I'm talking about the disease or the exemplars terminology of elimination. So in week 1, after we get through class orientation, we talk about kidney stones, benign prostate hypertrophy as components of elimination. But those are abnormal or they're disease processes. So we should talk about the normal first. So what is the normal anatomy and physiology of the concept of elimination? So in this case, we're talking urinary elimination. So I'm very big on anatomy and physiology. So where are my kidneys? They are in my lower back, also referred to as flank, F-L-A-N-K, not flank steaks if you love steaks. And we have 2 of them, one on the left and one on the right. And your kidneys have a huge responsibility, and the acronym I talk about in class is a wet bed. And I break down the A, the W, the E, the T, B for bed, E, and D, a wet bed. So basically what we're doing is we're talking about the functions associated, how the kidneys manage when everything's copacetic. So what's really important to understand is that the formation of urine is made within the kidneys, within the system of the nephrons. And so if you're looking in your textbook, you want to be, these are our lessons or our objectives. Elimination is excretion of waste from the body. Bowel elimination will come in module 4, and that bowel elimination is inflammatory and digestive. But today we're talking about the urinary elimination. So you have to have a functioning kidney system. Yes, we can work off 1 kidney, but 2 is definitely a necessary function. And it basically is the kidneys or the nephrons that are responsible for collecting waste products from within our body, from our organs and our muscles to create urine. So we have, as you know, your lab work for BUN and creatinine. So let's just talk about those. So you have blood, which contains urea and nitrogen. Urea and nitrogen are gases, toxins, etc., that the nephrons within the kidneys pull out of the blood to be excreted in the formation of urine. Creatinine, on the other hand, is actual waste products from your muscles. So we want to pull off the waste products that our muscles are using throughout the day. And that's why you have BUN lab values and creatinine lab values, which gives us a fairly accurate assessment to some degree of how well our nephrons are pulling off urea, nitrogen, and creatinine to make urine. And within the urine, that's what you have for waste products. So those levels really look at whether the kidneys are able to pull off urea, nitrogen, and if not, what's going on with the kidney function, and that's part of the elimination. Or if we're holding on to too much creatinine in the bloodstream, we're holding on to too much muscle waste. So what's happening within the nephrons, which are the major component of the process of making urine. So with that being said, when we look at where our kidneys are located, so we have one on the left and one on the right, and then from each kidney, you have a ureter. And so what the ureter is doing is transferring the urine that's made from that nephron or from that kidney and dumping it into the bladder. So I got a left side nephrons, kidney, and I got a right side nephrons, kidney, and a ureter. A left ureter and a right ureter, and they dump urine in the bladder. All your bladder does is store urine. That's all it does. When your bladder gets full, you have nerves along the inside of your bladder that speak to your brain that tell you got to pee, void, urinate, eliminate, whatever language you want to use. And then from there, it goes out through the urethra. And the urethra is what is the last tube, if you will, to void. So men have longer urethras than females do, which makes women more perceptive to, or um, more to get urinary tract infections. Yes, it's the beginning of the semester. So we're more at risk for. And it's also important when putting a Foley catheter in that for 2 to 3 centimeters, it should be in a female's bladder, whereas a male urethra is much longer, it's 12 to 15 centimeters. So when you have a blockage within the nephrons or within the kidney structures itself, such as a kidney stone, you're going to have an obstructive process that's going to affect the elimination. So that's one of our disease processes we're going to talk about, quite frankly, next week. So we want to be able to understand the process of making urine, where the urine is made, how it travels from the ureters to the bladders to the urethra, and then out. Okay, and the sphincters are what propels the urine process forward. Remember, bacteria is ascending. So when we don't have really good pericare, we're not providing good pericare, we're not providing good Foley care, bacteria collects and goes actually up into the urethra, into the bladder, and can cause a urinary tract infection. A lot of folks will say the tract is the urethra. The tract is the entire formation of urine from the kidney manufacturing of urine to the ureters, to the bladder, to the urethra. So as we talk about stuff next week, and weeks after that, to correlating concepts in exemplars, you will see that the urinary tract can be quite dangerous regarding a lot of disease processes outside of enlarged prostates for men, UTIs, male and female, and other things we'll talk about. So defecation, some learning activities. If I were in a group, I'd ask you to tell me a little bit about this. So defecation is the language for bowel movements. Mictration, I think I would have to look that up. So what do you think mictration means? Any thoughts on that? Mictration? All right, well, I'm a big Google girl, so we're going to Google it together. So mictration, there it is. The definition is the action of urinating. So there we go. Voiding is urinating. Continence. So we talk a lot about incontinence. So incontinence, continence is the ability to hold urine regardless of whatever's going on. So we have good bladder wall, we have got good bladder muscles, we've got good bladder control. Incontinence, on the other hand, we usually have stress, stress incontinence, mechanical incontinence, a bunch of other types of language, but incontinence is the inability to maintain urine within our bladder. And that's also an increased risk for UTIs as well. Retention is an abnormal clinical finding, and that is where we're not voiding sufficiently. Either we're not emptying out our bladder, or we're not voiding at all. And so those are not active, or I should say those are not effective, those are not positive signs. So retention's not a good thing. All right. Scope of concept includes a normal expected physiological process. I did talk about the urinary impairments as well as problems. Review bowel. So we're going to focus on urinary elimination. So I talked about the bladder, the urethra, internal and external sphincters. So sphincters are, I'm trying to give you an example. They're usually circular in motion. They're muscular or ligature in composite, and they squeeze and open to move product from A to Z. So you have sphincters in your urinary elimination system, which helps move urine out of the body, and you have sphincters in your large intestine or your colon, which helps move stools through the process from the right lower quadrant and up and around and out, and we'll talk about that more. Peristalsis, just since we're on it, peristalsis is the active digestive process when you put food in your mouth. It's the GI system or gastrointestinal. From the time you put something in your mouth, you activate digestive enzymes that process that food from the time it goes into your mouth until the time you either excrete and or defecate. Gastrocolic reflex, we'll talk about pediatric enteritis in I think it's week 3. And reflux is not necessarily a good thing, and we'll talk about that also with peptic ulcer disease. What else we got? Variations in context. Fecal incontinence, we'll talk about that. It's the same thing as urinary incontinence, the inability to hold stool in place within the left lower quadrant. Retention is self-explanatory. Discomfort, urinary tract infections in premenopausal women, so before women start menopause, is uncomfortable, very painful. Postmenopausal women, these are 55 and older, we lose a lot of our sensations, so UTIs go undetected because we don't have burning sensations when we void, and that increases the risks of your elderly females falling and breaking hips and or having delirium. So you have an automatic issue right there that UTI should be considered one of your sources for that. Infections, inflammation, the infections of the UTI, inflammation is going to fall with the kidney stones, BPH, and glomerulonephritis. Don't worry about the language, we'll get there. Neoplasms, we talk about cancers. You have a cancer overview in 112, and I'm just going to speak out loud. If you've already had 112, you've already had an overview of cancer, but we know that this particular semester you all are in 112 with me. So we're going to do prostate cancer as well. In organ failure, we can have chronic kidney failure for whatever reason, typically diabetes, uncontrolled hypertension, other situations that can cause somebody to need dialysis. Types of urinary incontinence. I'm not going to spend a whole lot of time on this, but I do want you to be aware of stress incontinence and urge incontinence. I don't lose my mind on definitions in this class. You're not going to get questions on an exam to pick the definition of a word, terminology, but terminology is important when it comes to clinical understanding of what your patient's experiencing while hospitalized. So stress incontinence and urge incontinence are important to know. And urge incontinence is the need to void. And there's an urgency to it that I got to get to the commode quick and fast. So that's going to come up with kidney stones. Stress incontinence comes up with coughing, sneezing, and jumping, where the stress of activity on the bladder causes the bladder wall to weaken over time. Multiple vaginal births, whether even if they're C-sections, will put stress on the bladder from carrying pregnancies. So be mindful of that. I'm not going to lose my mind overactive through transient. So I did talk about good peri-skin care is necessary, but losses of stress, loss of urine and or bladder can cause skin breakdown, pressure ulcers, excoriation to the peri area, can affect relationships, can affect patients going out and being sociable. When we get to perfusion toward the end of the semester and patients are on diuretics for heart failure and they have stress incontinence, so heart failure is a broken heart later in life. So if I'm already have stress incontinence, it's going to be worse because I'm on a diuretic that's going to make me pee. And so that can change activities, going out with folks, doing shopping, driving, embarrassment. You can have body image disturbance, things of that nature. So there's a lot more involved than just the A and P side of a nephron. Basically, the backflow of the urine due to an obstruction such as a kidney stone, inflammation of the nephrons, UTIs, anything that's going to cause the dysfunction to the normal process of elimination is going to cause urinary retention, which sets your folks up for UTIs. Long-term, huge risk factor, which usually, if not treated in a clinical time frame of reversibility, is what's called hydronephrosis. So hydro means to shrink, and therefore I have shrunk my nephrons, and therefore you have reduced and or eliminated the ability of your nephrons to create urine, and therefore you're in chronic kidney failure, and that, my friends, is permanent. So that is worst case scenario, and that's what we want to avoid when we talk kidney stones and BPH and glomerulonephritis. Bowel retention, just the urge to go. We have issues of constipation, impaction. I'll talk more about those specifically when I deal with digestion and inflammation as a concept. Factors that place individual at risk for elimination problems. All right, well, we talked about age, gender. I always talk about the concept maps is something I'll talk about in detail on Monday. And then again in class on Tuesday. Concept maps or outlines, I don't care how, I do care how your brain works, but it doesn't matter to me what source of study material you use. But when I find students having massive amounts of resources to discuss one particular disease process, I know for a fact you're overwhelmed. So a concept map gives you, or an outline gives you 6 specific areas to focus on as it relates to that disease process. So population at risk for urinary elimination issues usually is based on age, gender, and race. And we talk specifically, for example, benign prostate hypertrophy, older men. Women do not have prostates. So your prostate enlarges on the male side, and that affects urinary elimination. Race, African Americans have a higher risk for acute kidney injury and chronic kidney failure versus white men or Caucasian. Urinary elimination risks of children, bedwetting, for example, trauma-related, other factors that we'll discuss. Pregnant women, I mentioned, the multiple pregnancies will cause the bladder wall and the muscles supporting the bladder to become lax over time, and that's going to cause stress and or urge incontinence. Older adults, just because as we get older, everything gets old with us. So things don't work as well as they used to, even if we're in perfect health and have no comorbidities. So that's one of those concept boxes under populations at risk. So you can garner, when you go to do clinical, you have a 55-year-old male who came in for a TURP, which is a surgical procedure to remove or part of the prostate. Well, right there, you've already got part of the concept map that's driving you to that population. So you're already a step ahead of the game, and that hopefully will help increase your confidence in clinical. So neurological impairment, folks with spinal disorders where there's no communication to the bladder to pee, quadriplegics, paraplegics, children born with spina bifida, multiple sclerosis, stroke patients. So those neurological impairments, altered mobility, patients may be wheelchair bound. For example, cognitive impairment, they could have dementia, they can have Alzheimer's and losing the thought process of cognitive, knowing their bladder's full and they have to pee. Congenital defects, I mentioned spina bifida, medical conditions, diabetes, hypertension, the list can go on and on. So those are the risk factors that can be associated with impaired elimination. So it's mindful that you are looking at this holistically, as the name of the course, Holistic Health Assessments. Recognizing when individuals have problems with elimination. So now you've gone from part of the concept map to clinical manifestations within the concept map. And this is called assessments. So your clinical manifestations are, how are your patients presenting? What is the assessment subjectively and objectively your patients are seeing? So do they have urinary elimination? Did I miss something? No, I didn't, sorry. Do they have urinary elimination? And what is the physiological perspective? Why is there urinary retention? What medical history, what social history, what surgical history could they have that's causing urinary retention, retention of stool? Why is there urinary incontinence? Why are they having discomfort with bowel elimination? Do they have colorectal cancer? Do they have tumors in the bowel? Do they have ulcerative colitis, or do they have Crohn's disease that's going to cause problems with bowel elimination? Urinary discomfort, do they have problems with UTIs? Do they have anatomical disfigurement or congenital defects that make elimination problems exist? So what is your assessment? History, ADPI. All right, assessment. We really don't talk a lot about diagnosis anymore, but what is your hypothesis? What do you think is going on with your patient when you collect your data, your objective, your subjective data? You look at those patient populations, you look at the history, you look at the medications and start correlating it back. What's going on with the patient, right? So do they have multiple sclerosis? And if they do, then most likely they have urinary retention. So what does that look like? All right. So what medications are they on? Do they have altered mobility? And MS is a neurological disease often associated with women more than men. And you will cover MS, if you will, in 211. But when we look at the history and examination findings, the inspection, auscultation, and palpation are specific assessments to the abdomen, because that is where our bladder is located in the pelvic region. So therefore, you're looking first, then you're auscultating, and you're going to hear bowel sounds and or peristalsis, and palpating. And percussion is more of an advanced NP, but we can percuss as well. But this is a focused assessment. Do we have abdominal distension when the patient's flat? Do we have bowel sounds in all 4 quadrants after 10 to 15 seconds, things of that nature? Does there pressure when we palpate? Does the abdomen feel like a soft pillow? Because if it's hard and distended, that's abnormal. Diagnostic tests, I refer to the BUN and the creatinine, but a urinalysis is phenomenal. Have them pee in a cup. Renal function tests, we can do a culture to assess for bacteria, and sensitivity, CNS, the sensitivity is culturing the bacteria or the pathogen, and then finding out what specific antibiotics will work in specific versus broad. Like penicillin is a broad antibiotic, which is why so many people are allergic to it, because we used it for everything back in the day. And does patients have blood in their urine, or do they have blood in their stool and we can't see it? Pathology, do I have prostate cancer? Do I have colorectal cancer? We can do CAT scans, MRIs. These are more conducive to organ assessment, tissue assessment, muscle assessment. Your x-rays are more towards your bone layout of the body, if you will. You can do a chest x-ray of the pelvic region just to ensure the hips and the pelvic region's intact, but you're really going to have better assessments with a KUB, which is kidney, ureter, and bladder. It's going to assess function, etc. You have your colonoscopies. We're going to talk about those as well. Sigmoidoscopies. We can actually do, remember, we're always going to do non-invasive before invasive, and I know blood work may strike you as being invasive, but when you do a colonoscopy or any of your scopes, look at your suffixes on this, then you're looking at more invasive. Cystoscopy and uroscopies are actually tubes with lights, just like colonoscopy, but we go up within the urethra to the bladder and be able to visualize the bladder, the ureter, and see what's going on in there. And that's also called bladder stress testing, urine flow studies, all kinds of things to get at what I call the expedition, fishing expedition by the providers, as to we really don't know what's causing these patients' manifestations. We don't know why they're having urinary discomfort. We don't know why they have urge incontinence, etc. So these diagnostics, I call them fishing expeditions, to try to figure out the hypothesis of what we think is going on. Appropriate nursing and collaborative intervention. So now this is part of your prioritization of your ADPI and implementing your process of fixing. So when you're implementing your interventions, which are your doctor provider orders, how are you prioritizing? What are you going to do first, second, and third, and why? All right, so we're looking at how we're going to fix a few things. So primary prevention, is there anything going on environmentally that we can look at? Maintaining hydration. You can go into acute kidney injury, AKI, because you're dehydrated. Dietary fiber. Do we have enough fiber in our diet to help promote production and movement of bowels? Physical activity. The more we sit, the more uncomfortable, I'm sorry, not uncomfortable. The more we sit, the more immobile we are, then quite frankly, the more constipated and or urinary retention we're going to have. Obesity plays a role in that as well. In regular toileting practices, I know in 111 you talked about those And we'll talk more about regular scheduling and functions of patients, especially those with neurocognitive disorders such as Alzheimer's disease, dementia, delirium, where to reduce UTIs, incontinence, pericare issues, skin breakdown, having regular toileting, having habits set forth for these patients, because they're losing the ability to remember to go to the bathroom. Screening. Yeah, I talk a lot about screening for colonoscopies because of the high risk of colorectal cancer in this country. Prostate cancer we talk about next week as well. We talk about who should undergo these screening procedures, when, who, age groups, and we'll talk about those at length. Who's higher at risk, genetic predisposition, family history automatically puts everybody in a higher category outside of the CDC or the Center for Disease Control. When do you have colonoscopies done? Well, if you've got a family member, and I know that either Gideon's or Iggy, which is your med-surg textbook, is going to talk about first, second, or third generation, dictates how many years. So let's say my dad was diagnosed with colorectal cancer when he was 55. Technically, my colonoscopy start at 45. I don't care what generation it is. It's family history is family history. So women who've had breast cancer, and it's first line moms, and she was diagnosed at 35, biological moms at 35, their daughters are getting mammograms at 25. So if there's no history of cancer, then the CDC guidelines will be what your provider would go by and what we would teach our patients. So we'll talk about those more specifically in class. Collaborative interventions, everybody's involved. You don't work at the bedside in silo. And I am teaching this course from a bedside clinical presentation as best as that I can. To me, wherever you go to practice, the best that we can do clinically at this level in your education is help you develop what your clinical bedside practice will look like. So it won't matter where you go as an RN, you take that practice with you and you evolve and develop it. But most students coming into 114 and 112 don't really have necessarily, they have a great foundation, but moving that foundation to the next level. And that is, what do I want my clinical bedside practice to look like? Where do I start? What do I ask? What do I do? So that's what a lot of 114 does. And the collaboration piece of that is working with your fellow peers, the RNs, the staff, medications. We can use dietitians. We have therapy, PT, OT, speech, etc. Diagnostically, what we talked about, these patients going to go down for a colonoscopy. The GI lab is part of our clinical component. So you're not at the bedside and you're not working alone. So don't ever think that. We'll talk about our medications. We do teach a lot of medications. Let me back it up. We talk about classification of medication. So for example, this slide talks about antibiotics. Well, what are the best antibiotics to use for somebody who has a urinary tract infection? How do we manage stress and or urge incontinence with antispasmodics? Think about the sphincter reflex and the spasms that UTIs can cause, which increases incontinence because the spasms from the bacteria infiltration. What can we do to manage constipation? Milk of magnesia, Dulcolax, Colace, analgesics for pain management, opiates in particular. So we talk about medication classification, and then you're going to get one prototype. So your analgesic for next week, for example, the opiate we're going to talk about under that is Dilaudid. So we talk about opiates and the medication of opiate, and your prototype is Dilaudid or hydromorphone. So we're going to talk about both those in depth. Of course, we have surgical interventions, dialysis with chronic kidney failure, kidney stones, removing kidney stones. We'll talk about procedures involving that. Nephrectomies, yeah, there's pieces that we can take nephrons out. I talked briefly about prostate surgery, bladder surgeries, urinary diversion. So be sure that when you're looking at concept 15 in your Gideon's book, you're spending some time talking about or reviewing procedures that are noted on page 172, and that's the hard copy. I don't know what the page is for the ebook. and just hear me out. The word on the street is that students or people, we don't like to read. And I hear sometimes that reading's fundamental. Well, that's great. I get it. But what I teach you in class is what I feel as a nurse practitioner and a seasoned educator to be what you need to move forward successfully in 114, but also to improve your classroom clinical knowledge for these particular disease processes. But I philosophically, cannot teach you everything, but I do focus on what I consider the most pertinent for you to be safe and quote unquote minimally competent to be successful class and clinically in 114. But you got to meet me halfway. All right, it's a 50-50. I really have a hard time doing 70-30, 80-20, 90-10. I do, however, do that. I do put in a lot of work into this class. I love what I do. But I need you, if I ask you next week in class, all right, tell me what a nephrectomy is. Well, I need you in your textbook and to know that, okay? We're almost done, kids. Bowel elimination, surgical, hemorrhoid removal, colectomy, that's a portion. So when you're looking at suffixes, so the last 3-4 letters of a word, that's in the medical terms going to speak to procedures. So if I've had a colectomy, I've had a removal of part of my colon. If I've had an ostomy or a stoma, I've had a diversion. If I've had a hemorrhoidectomy, I've had a removal of hemorrhoids. All right, so colectomy, I've had a removal of a portion of my colon. So if you, and I know we don't offer a medical terminology class via the program, but it is offered at school here. It's online, it's 2 credits. Matter of fact, it's reminding me I'm going to sign up for it because I want to take the class. So bear with me. So with that being said, if you understand the suffixes behind the medical terms, then you understand the surgical procedures. You may not know necessarily where the procedure in the colon took place, but you understand that if someone had a colostomy or an ileostomy, they're going to have a bag of stool from the colon, or an ileostomy, they're going to have a bag from the last part of my small intestine, which is my ileum. And that's going to be what you need to understand, because your product in that bag is going to be very, very different in consistency. And that drives a plan of care. Nutrition, fluid electrolytes, acid-base balance, mobility, cognition. All right, nutrition is very important. I'm very much about the DASH diet and a diabetic diet, and I'll talk diet out the wazoo all semester and it won't change. Fluid electrolytes and acid base you'll learn in 112. I'm going to get to elimination before you do acid base and fluid electrolytes, so I'm going to focus just on what I need you to know for fluid electrolytes and acid base. It refers to urinary output and digestion when we get to Crohn. So don't freak out on me, okay? Mobility, I've talked about that. If you're not mobile, you're not up moving around, or you can't get up and move around for whatever reason, you're going to have retention issues. Cognition, I talked about delirium, Alzheimer's, mental health impairments, etc. All right, well, we're not brainstorming, so let's see what else we got. Featured exemplar, so we focus on BPH, colorectal cancer, kidney stones, talk about urinary tract infection as a backup, constipation, diarrhea, more from an inflammatory bowel, not irritable, and of course renal failure. We speak to that as well. So that's what I got. I'm done. I will post this to module 1, and we're cool. Peace out.